Hello everybody, this is Dr. Gopi Krishnan, an anesthesiologist working in Chennai. While thinking of taking a lecture series to the sisters working in my ICU, I thought of coming out with this pre-recorded orientation program for ICU nursing profession, which will be including 20 different lectures, which is shown in this screen. That includes foundations, cardiac, respiratory, neuro, renal, metabolic system evaluation and management, pharmacology, nutrition, prevention of injuries, emergencies, and also includes communication, ethics, and quality, paperwork, and auditing aspects as well. Hope this will be useful for you, and I want all of you to utilize this orientation program. As a part of this orientation program, this is session 1, an ICU orientation, roles and responsibilities, and understanding the unit layout. So the learning objectives of this session is navigating through your ICUs, identification of zones and equipments and its identification and its exact location, and thoroughly understanding the utilization of crash carts, isolation rooms in a confident manner, and understanding team roles. You in an ICU will be a part of a system which includes many peoples. There are includes intensivist, nursing in charge, respiratory therapist, pharmacist, infection prevention and control nursing group, and housekeeping department. In this entire group, you will be working as a shift pattern that includes either shift that includes handing over and taking over, that includes patient nurse ratio coverage and its your roles and responsibilities, and its break and its coverage. And there is an escalation policy. So use the chain of command to escalate the clinical and non-clinical concerns to the appropriate persons. What makes an ICU different? So here in ICU, we deal with patient in minute to minute and hour to hour basis. Based on the fresh reports or findings coming up, the treatment plan will change accordingly with minute to minute, hour to hour importance to the patient's clinical scenarios. To maintain that, the nurse to patient ratio should be maintained with 1:1 or 1:2 based on the patient severity index that will be covered in this lecture. And we do 24/7 monitoring with continuous multi-para monitoring to all the patients, which involves the specialist coverage. In an ICU, there is a chance of 5 times more risk compared to the general ward. And the time to respond to code blue or arrest is less than 6 minutes or immediate. So key features you will encounter in an ICU today is you will see ventilators, infusion pumps, dialysis machines, defibrillators at every bedside. You will get to see multi-para monitors with central station with alarm systems in every key ICUs, and there will be fully stocked crash cart, intubation tray, and difficult airway cart, which needs to be checked in every shift. And there will be negative pressure isolation rooms which will be allotted to appropriate patients based on their clinical indications. There are different types of isolation base. One, it involves droplet types of isolation, another one is contact types of isolations. And round the clock consultant intensivist availability along with senior residents on site to provide patient care. And the ICU team, who does what? So what does an ICU team involves? Who are all will be a part of this, and what is their role? So it mainly involves the consultant intensivist, who is the lead role and the final decision on management. Regarding the escalation and end of life care will be decided based on the intensivist and the patient's discussion based on the patient's clinical scenario. And there will be a senior or junior resident who will be taking care of the first line of clinical response, orders, procedures, and communications. Regarding the nursing in charge, there will be shift-based nursing in charge. They will be taking care of the bed allocation, staffing, escalation, and audit oversight. And bedside ICU nurse will be taking care of the continuous monitoring, charging, drug administration, and family liaison. Regarding the respiratory therapist, they'll be taking care of the ventilator setup, ABG sampling, nebulization, and suctioning support. And regarding the clinical pharmacist, they will be taking care of the drug reconciliation, dosage in renal and hepatic failure patients, and high alert medication and its checks. Regarding the infection prevention and control nurse, they will be taking care of the bundle audits, outbreak investigations, and hospital acquired investigation surveillance as per the NABH norms. And the key people, the housekeeping and the CSST department will make sure the terminal cleaning, the instrumental sterilization, and the waste segregation aspects. So this image depicts a schematic image of an ICU layout which involves various beds, cabins, and the space is allotted for nursing station, isolation, storage area, and the crash cart area and the doctor's area. So everything is different as per their setup and the hospital's convenience and the space availability of each institution. So one has to go through the ICU layout thoroughly as per their working area and the hospital availability. On day one, walk every bay twice. By the end, you should know and you should be able to reach the crash cart blindfoldedly. Every second counts in a code as an added point. Next, the crash cart, your best friend in a code. So there is a standardized layout, the sealed lock, and checked every shift. Know every drawer and the drugs and instruments available in the crash cart, which has different priorities. The top priorities includes defibrillator and monitors. Check the paddles, ECG leads, conductor leads, spare battery. And next, the airway and breathing systems that includes laryngoscopes, endotracheal tubes, stellate, bougie, laryngeal mask airway, ambu bags, and oral airways. Next, the resuscitation drugs that includes adrenaline, atropine, amiodarone, lignocaine, calcium gluconate, soda bicarbonate, and dextrose 25%. And next, the IV access and the fluids that includes the IV cannulas from various size, starting from 14 to 22 gauge, and the centerline kit, intraosseous needle, and arterial line set, NS and oral, syringes, IV sets. Regarding the procedures and documentation aspects, suction catheters, NG tubes, chest drain kits, gloves, code blue, and record sheets will be handled. Regarding the shift structure and chain of command, know who to call, when to call, and how to escalate. So there is a shift pattern. Most of the cases there will be a morning shift, evening shift, and a night shift, and the timing according and convenience as per the team working over there and the administration part. Next, the patient ratios, the nurse patient ratios as per the NABH. There are 3 levels of patients' criticality based on their involvement and their clinical status. Level 3 ICU patients includes ventilated and multi-organ system failure patients, demands 1:1 ratio. Level 2 HDU patients or step-down patients or an improving or recurring patients. One nurse can handle 2 such patients. In level 1 post-op observation patients, 1:3 can be accommodated. Always confirm your bed allocation at handing over. If overloaded, escalate it to nursing in charge immediately, because the quality is more important than the quantity. Next, the escalation pathway. Level 1, bedside nurse, your assessment and immediate intervention. Level 2, nursing in charge. They'll handle the staffing, equipment, conflict, and minor clinical work as well. Level 3, junior resident or SR, all clinical changes, new orders, and procedures. And level 4, consultant intensivist, major clinical decisions, deteriorations, assessment, and discussion with the families and decision making. So the how this session maps to NABH 6th edition and how things are correlated with each other. In AAC aspect, patient is admitted, assessed, and transferred safely within and to the ICU. Bed allocation, handover, continuity of ward, and ED can be handled. Regarding a PSQ aspect, critical care readiness, escalation pathways, response to deteriorating patients, and SOPs, code blue activation, all are PSQ based requirements. Regarding the facility management and safety aspect, the unit layout, isolation rooms, assessment, facility functioning, equipment maintenance, biomedical and engineering safety in the ICU are the key aspects under facility management. Care of patient defines ICU as a special area requiring documented protocols, qualified staffs, equipments, monitoring, and nursing care. Regarding the human resource management defines staffing patterns, nurse patient ratios, credentialing of ICU staffs, induction and competency assessment. Regarding the responsibilities of management, chain of command, clinical leadership, governance of ICU as a clinical service. The key change in 6th edition is HAC, Hospital Infection Control chapter, is now called as IPC, Infection Prevention and Control. The key takeaways from this session that includes know your unit cold, which means understand your area of work, the ICU fully, thoroughly, the number of beds, the isolation rooms, the equipment and its functionality and its operations, crash cart, the store, doctor's room, and the hospital facilities availability for intercoordination. The ICU is a team. Use first names, know your roles, work hard to ensure the patient outcome, and never hesitate to ask. Follow the 4-level escalation pathway from bedside to in charge to the resident doctor, then to the consultant. They check the crash cart at every shift handing over. A sealed cart that has never been opened is one you can trust in an emergency. Maintain nurse patient ratios. Flag overload immediately. These are the MCQs based on the lectures that I have conducted for the past 20 minutes. So pause your video, take a screenshot, and post your answers in the comment section. I'll be waiting to see your answers. And next will be the session 2, infection prevention, hospital infection control, the PPE, bundle care, etc. regarding the WAP, CLOBC, CORT, SSI bundles in detail in the next session. If there is any questions, feel free to comment under this video. I will be happy to share my inputs. Thank you. Bye.